from you the portion of the overview of the upper limb. I will need the part of the bones of the upper limb, as you can see, as well as all of them. Like these are the bones of them, like a clavicle, a scapula, like a part of the humerus, as well as the bones of the represented by the ulna and the radius and so on. I'm sorry. Also, we will go through the part of some surface anatomy here. The part of the vascular region and so on, I don't need it, and innervation, I do believe it's clear. But I will need the part of the muscular structures, such as here you can see the part of the pectoral and scapular regions, anterior axial-appendicular muscles. I will need posterior axial-appendicular muscles, scapulohumeral region, and some surface anatomy also. I will also talk about the axilla. We will cover this part also, although without the arteries, veins, and the lymphatics and so on, and brachial plexus. And then we'll go through every and each part, like an arm, the part of the arm, what are the muscular structures there, the forearm, and so on, as well as all of these parts. I will need the joints of the upper limb, which we'll also go through. Today, I will talk about the bony structures. Tomorrow, I will talk about the joints of the upper limb. And then from the next week, I will continue with the muscles of the upper limb, and we'll continue according to our syllabus. So as a result, starting from the very first part to talk about the general consideration of the upper limb, so like an overview here. So first of all, the upper limb itself is a region of the body, as we know, yes? Although we have some subdivisions of it, and here you can see some parts and segments of the upper limb. Just a second. This is better like that. So first of all, we do have a portion of a shoulder girdle, and or also known as the pectoral girdle, where we do have a part of the clavicle and the scapula, which are mainly representing the girdle structure. To be honest, in the case of the of the whole upper limb, that's what we call literally the appendicular skeleton. You remember? The whole skeleton was divided into the axial one and appendicular, yes? So when we were talking about the vertebral column, when we were talking about the thorax, sure, this everything was mainly associated with the axial skeleton. Now, in the portion of the upper limb, we are literally talking about the appendicular skeleton, which is composed of the shoulder girdle, as I said. So where we do have the where we do have a clavicle and the scapula. Why I said that, why I started to classify, because if we talk about the appendicular girdle, it means that it should have the attachment to the axial skeleton, yes? So there should be some articulations with the axial skeleton. And what are the articulations here? So here, in case of the clavicle, it is the one which helps us to produce this particular articulation. And as a result, the clavicle, compared to the scapula, is the only bone which will make the articulation with the sternum. Do you remember the sternum from the thorax part? So that's where we had, you remember the part of the sternum composed of the manubrium, body of the sternum, and the xiphoid process. And in the part of the manubrium, we had the portion of the clavicular notches. And the clavicular notches were providing for us the attachment, or correctly to say articulation, with the appendicular skeleton, particularly with the clavicle of the appendicular skeleton, yes? The part of a scapula, how surprising it wouldn't be, the scapula is the one which does not contain the direct bone-to-bone articulation with the axial skeleton. You know, there is really no direct articulation. As the result, the scapula is like, you know, imagine that it is suspended in the large amount of the muscular structures, I mean, surrounding it and attaching to both the appendicular as well as to the axial skeleton. Although in the case of the appendicular skeleton, you can see that the scapula containing on its lateral side, it starts to attach to the humerus of the arm. This is the region of the arm, or also we call it brachium, please remember. And sorry. And as a result, we have a formation of its shoulder joint between the scapula and the part of the humerus. Also, we call it glenohumeral joint, just because this lateral region, and we'll talk today about that. This lateral region, this angle, lateral angle of the scapula is literally, as you can see here, containing the like the invagination, which we call the glenoid cavity, and this particular glenoid cavity will produce the glenohumeral joint. So here, as we said, the part of the segments that we have here, we have the arm, or also known as the brachium, as I said, till the part of the elbow joint. Here we do have a portion of the elbow joint where compared to all of the other joints here, we do have the articulation of more than two bones to each other. So from the side of the arm, we do have the humerus, as you can see, and from the side of the segment, which we call forearm, or also known as antebrachium. I do believe it's clear, yes. Why? So antebrachium, you can see that we do have two type of the bony structures. One is the ulna and one is the radius. And in an anatomical position, please remember that the ulna is always more medially localized towards the median plane, and the radius is always more laterally oriented in a case of the anatomical position. Okay, so as a result, the elbow is produced from the three different types of the bony structures. Here we do have a portion of the ulna and the radius. Then we do have a part of the hand region, or also known as manus. I do believe it's clear why we say everything is when we do by hands. That's what we call manually, simply to say. And in between of the forearm and the manus, we do have the region which we call the region of the wrist. And in this case, we do have the radiocarpal type of the joint. Why? Because when we talk about the whole hand, we identify the regions such as the carpal bones. Here we have 8 different carpal bones. We do have here the part of the metacarpal bones, so metacarpals, and here we do have a part of the phalanges, as you can see, which are mainly representing the digits of the upper limb. Okay, so as a result, in the case of the wrist joint, we have it between mainly the radius and the carpal bones, rather than the ulna, because you will ask, the ulna will also have here. That's true, but here the ulna is very small and most commonly does not produce direct bone-to-bone attachment to the part of the carpal bones. Till now, is it clear or not? Yes, or you have any questions? Okay, good. Just a sec. Wait for me for 2 seconds, please. Okay, I'm back again. Well, till now it was clear. Let's continue then. And sorry? Is the... No. No. Only first 5, if I remember correctly. I will recheck. Okay, in the end of this lecture, we'll talk about that. Okay, let me continue first with the part of the anatomy. Well, as we've talked about, the part of the some segments of the upper limb. Here we can also see that we do have some different types of the structures here, some different parts of the and some different regions, as you can see, of the upper limb. And starting with the very first one, you can see that we do have the subdivisions, let's say like that. starting with a portion of, for example, the part of a deltoid region, as you can see here, yes, with the part of the pectoral region, the part of the axilla, for example, the brachium, the part of the antebrachium, and so on. What I want you to understand is that, yes, although these subdivisions are important, but according to the functional anatomy, yes, we need to remember that mainly the movements what we have. So we need to remember the types of movements in the case of the upper limb. This you will understand according to the portion of the joint. For example, that the glenohumeral joint or shoulder joint, it's a type of the ball and socket. That's why it has the different types of the movement. Yes, not only extension and the flexion, also abduction, adduction, as well as circumduction, and so on, you know, and rotation. And a part of the elbow joint, what type of movement we have, and so on. Why it is important? Because to be honest, to understand the bony structures, it's really very easy. I mean, comparable, very easy to remember all of the muscles of the upper limb, because there are too many. That's why we need to connect it logically to these, not that much to these parts, let's like that, but more to the movements, you know. So as a result, let's continue with a part of the movements, no, sorry, not movements, the bones of the upper limb. And here the very first type of a bone that we have, this is particularly the clavicle, as you can see. So let's talk about the clavicle more. First of all, you see that the clavicle is mainly an S-shaped structure, has an S-shaped structure. Here you can see that from one side it has a sternal end, which is covered by the cartilage, because it has the sternal facet, and the sternal facet is articulating with the manubrium of the sternum, as you remember, in the clavicular notch. From the other side, we do have a part of the acromyal end. What does mean the acromyal end? And here we need to see that the whole clavicle is S-shaped structure, as you can see, comes towards the part of a scapula. Scapula is normally localized on the posterior surface of our body, and on the very posterior part of it, you can see that we have the projection. Do you see this one? That's what we call the spine of a scapula. The spine of a scapula, starting from the medial border going to the lateral side, it starts to increase and make like the turn, as you can see here. Okay, so this turn this turn goes laterally and anteriorly, and that's what do you see here. So it's a process which we call the acromyon. So this acromyon has the direct attachment or articulation with the clavicle. That's why opposite to the sternal end, to the medial end, we do have the acromyal end. So directly where it is attached or articulated with the acromyon of the scapula. What is also interesting for us is that here you see the inferior surface, here you see the superior surface. So in the case of the inferior surface, if you remember, when we're talking about the thorax, we said that in the case of a first rib, yes, we had the two grooves for the subclavian artery and the subclavian vein. Do you remember that part? So as a result, particularly the word itself, the name of the vein and artery, that they are subclavian, it already identifies that they are localized under or beneath the part of the clavicle. Yes, as a result, you can see here that on the inferior surface of our clavicle, we do have the groove of the subclavian, and as a result, you can also see that coming towards the portion of the sternal end on the inferior surface, you can see that for the attachment of the clavicle and being more stabilized during the attachment to the axial skeleton, you can see that we even have the part of the impression for the part of the costoclavicular type of a ligament, meaning that we do have directly the ligament between the clavicular part and the ribs. Why this happens? For example, if we'll see, although I will explain more about the joints tomorrow, but just for you to understand it better, look, These are bones, these are fascias, these are regions. No, no, no. Just a second, please. Yes, here they are. So, to be honest, a very nice picture. So, do you see? This is the part of a clavicle. Here we do have the sternoclavicular joint, which we've talked about. And now here you see that we do have a part of a very small type of a ligament on both of the sides, which we call the costoclavicular ligament. So one thing that the clavicle should be localized very much horizontally in the anatomical position, as you understand, because it bears the whole weight of the scapula, as you can see, on attaches and articulates it towards the sternum, and as a result, to be more stabilized, we do have not only the sternoclavicular joint with the part of the ligaments here, like simply sternoclavicular ligament from both of the sides, anterior and posterior, but also interesting thing that from the side of the clavicle, we do have the part of costoclavicular ligament, as well as through the jugular notch. Do you remember jugular notch here? We do have a part of the interclavicular ligament. Do you see how it looks like? Yes. Also, this is for the medial part of the clavicle and its stabilization. But from the other side, we said that we do have a portion of the acromial end, yes, of the clavicle. And in the case of the acromial end, which is attached to the acromion, sure, here we do have the acromioclavicular joint, which is also having the large capsule composed of the part of a superior acromial, for example, acromioclavicular ligament, yes, as well as interesting part that in between of the part of the lateral region of the clavicle, as well as the portion of the coracoid process. This is the small projection, this one and this one, coracoid process of the of a scapula. We still have the formation of the ligament. You see, so more stabilization of the clavicle comes here without any joint, simply, yes. So, and this is particular coracoclavicular type of a ligament. Why coracoclavicular? To make you to understand it better, let me show you back again the part of the bony structures of the upper limb, and here it is. Please look here. So do you see, this is the scapula, it's anterior surface, and here, but correctly to say not anterior surface, but the costal surface, which is more associated with the posterior part of the ribs. So here you can see this projection, as I said, coracoid process, and particularly here we also had the part of the coracoclavicular type of the ligament. And coming back to that picture, it is clear that this S-shaped structure of the clavicle is important for what? For the, first of all, stabilization of the whole shoulder girdle, and as a result, having so many different types of the ligaments. Now look, they tell you that in the case of the coracoclavicular type of a ligament, it is subdivided into part of the conoid and the trapezoid ligaments. And to be honest, it's also very logical. Why? Because here back again in the bony structures of the upper of the clavicle, you could see here the part of the conoid tubercle. Sorry. I'm sorry. Conoid tubercle, which you can see particularly here. Look. Conoid tubercle and a part of a trapezoid line. Why on the inferior surface? You remember the part of the trapezoid ligament and the portion of the conoid ligament, they were attached on the inferior surface of the clavicle, yes, and then towards the coracoid process. As a result, we have the coracoclavicular ligament, which is subdivided into two parts, and these parts are according to their attachment to the inferior surface of the clavicle. This part is clear or not? Do you have any questions in this part? Good. So in the portion of the I'm sorry. In the part of the clavicle, what is most interesting for us is that the sternoclavicular joint sometimes is so much strong that in a case of the fracture of the clavicle, we have it in on the shaft of the clavicle, right? And particularly in case of the joint between the sternum and the clavicular structures, you know. So sorry. As a result, in the case of the fracture of the clavicle, the whole, like, it works like a leverage, imagine, from the for the whole scapula and then the free upper limb. And as a result, in the case of a fracture of the scapula, there is no, sorry, the fracture of the clavicle, most commonly there is no way to move the upper limb because the leverage is lost. So like the whole, because the whole what's like that force during the movement still comes on the region of the clavicle, yes, as it is attaching the upper limb toward the only thing what attaches the upper limb towards the actual skeleton by the articulation. Okay, so when we go to the next part, when we said about the region of the shoulder girdle, we said that the second type of the bony structure, which is also localized here, this is our scapula, as you can see, and particularly the scapula is seen to show us. You can see you can see it here. That's how it looks like. So you can see that it looks like simply the triangle, and the triangle which has its medial border towards the vertebral column. That's why what you can see here in the schematical representation. So you do have the medial border towards the vertebral column. You do have the lateral border as well as the superior border, as you can see here. Also, you do have, as it is, the triangle. That's why we have the three angles in this case. One is inferior, one is superior, which is logical, and one is lateral. Although in reality, the lateral angle is not a real angle, as you can see here, because here we do have the shallow invagination, which we call the glenoid cavity, and the glenoid cavity is the one which is covered by the cartilage. Why? For the formation of the shoulder joint, as you see here, or also known as glenohumeral joint. Now, why glenohumeral joint? Because it's very interesting. You can see the glenohumeral joint in this case. The glenohumeral joint is, yes, for this picture, doesn't matter. So the glenohumeral joint is the ball and socket type of a joint. Because you can see that glenoid cavity is literally a shallow and invagination, and it is producing the like a socket. And in the case of the humeral region, the head of the humerus is literally the like a ball shape, you know, like a spherical. And as a result, when it is residing in the glenoid cavity, that's why we call it the ball and socket. As a result of that spherical structure, the movement of the upper limb in the shoulder joint is really very extensive. And as I said, it can be like any type of movement, starting with a simple flexion extension, continuing with the rotatory type of movements, as well as the circumductory type of movement, and so on. So coming back to the to the part of the scapula. Just a second. Yes, let me open it like that. So coming back to the portion of a scapula, what do we see here is that also is that we do have two surfaces. Yes, the one surface, as I told you, although yes, it is anterior because it's anteriorly oriented, but in reality, it is localized on the back, and it is associated with the ribs, on posterior part of the ribs. As a result, we call this surface the costal surface, and the opposite to it, the one which is seen on the back, that's what we call particularly the posterior surface, as you can see. And as we already said, the posterior surface contains the large projection, which we call spine of the of the scapula. And the spine, as you can see here, do you see how it looks like? It has some projections even. We do have a part, for example, for the deltoid tubercle here, as you can see, the projection of the acromion, as you can see here also. And this acromion, as we already said, contains the facet for the articulation with the clavicle. So to produce the acromioclavicular joint, as you can see. Now, what is interesting here also, that the parts of the scapula contains the small projection, which we already talked about. This is the coracoid process. It is more anteriorly, or let's like that, localized or oriented anteriorly, yes. And as we said, mainly has the important function, and you can see it here, by the way. It produces the attachment to the clavicular acromial end of the clavicle. And as a result, here we do have the formation of the coracoclavicular ligament, which we've talked about, which was mainly subdivided into two main parts. As I told you, it was the part of a trapezoid and the part of the conoid type of the ligaments there, according to the structures localized on the clavicle. Now, we said about the spine of a scapula, and we said that the spine of a scapula, you can see, is dividing the whole posterior surface into two regions. This is, now look, the names are very logical. If it's a spine of the scapula, then anything what will be superior to it will be the supraspinous fossa. Do you see? Supraspinous fossa, so superior to the spine of the clavicle. Lower to it, as you can see, you have the infraspinous fossa, so simply to say, lower to the spinous process of the scapula. As a result, these two fossas are the ones which are giving rise or providing the attachment to the muscles. For example, we call these muscles rotator cuff muscles, which are surrounding the whole scapula, and as a result, we do have here the formation of the how to say, it's like surrounding the whole scapula. That's why we call it this rotator cuff. You know, like a cuff surrounds the portion of the glenoid cavity. By the way, we saw it right now when we're talking about the glenohumeral joint. Here they are. Look, these are the rotator cuff muscles, as you can see. So we do have here the part of the supraspinatus. From the name, I do believe it's clear, yes? Superior to the spine. We do have the infraspinatus, which is inferior to the spine. Subscapularis, which is under the scapula simply, and also the part of a teres minor. So as a result, all of them together, do you see their tendons are overriding or crossing the part of the shoulder joint, and as a result are attached to the part of the head of the humerus. So as a result, you can see here what I was talking about in the part of a scapula. Look. So in a part of a scapula, when I said that we have supraspinous fossa, as a result, the rotator cuff muscle which will be attached here is the supraspinatus. In the lowermost part here, we do have infraspinous fossa. As a result, the muscle which will be attached here is the infraspinatus. And from the costal surface, so like under the clavicle, we have the muscle which we call the subscapularis, because it is literally localized under the scapula. So that's why this region we call it subscapular fossa, as you can see. And the part of a teres minor is associated with the lateral edge or lateral border of the of our scapula, and as a result, from all of the sides, these muscles are producing the rotate, like a cuff for mainly the rotatory type of muscles. Is that part clear? Although not all of them are in reality giving us any type of the rotation. For example, in the case of a supraspinatus, when we talk about the abduction, for example, yes, do you remember abduction? Do you remember abduction? So away from the midline. Normally, abduction is dependent on the deltoid muscle, although approximately first several degrees, of the abduction, it's like approximately 15, is dependent on the supraspinatus. So this is the one which starts the abduction, and then only the deltoid region will help to make the complete abduction. You see? Okay, till now, was this part understandable or not? Do you have any questions in this case? Okay, it's clear. Let's continue then. And a part of the glenoid cavity, what is also interesting for us, we have some irregularities which we need to remember. And these are the parts of the supraglenoid tubercle and the infraglenoid tubercle, meaning that one tubercle is localized superior to the glenoid cavity, the second one is localized inferior to the glenoid cavity, as you can see here. Why we need them? Because in the future, when we'll cover the part of the muscles of the upper limb, we will see that some of them, particularly the muscles of the arm, are having the attachment to the supraglenoid tubercle as well as the infraglenoid tubercle. Okay, so here we do have lower to it, we do have the lateral border of the scapula as well as an inferior angle. So what are more irregularities in this case which we need to remember, and not only irregularities but some additional information, is that please remember that when we were talking about, and recall this information, when we're talking about the movement of the scapula, we said that we do have protraction and we do have retraction. Am I right? Do you remember that? So retraction and protraction. Okay, so in the case of the if you remember, the retraction and protraction were mainly the same as the retrusion and protrusion. Yeah, so where we had the protrusion, so protraction, anterior and the lateral movement of the scapula, and vice versa, we had more medial and posterior movement such as retraction. Do you remember? Why I'm reminding this here? Because going next to the tomorrow to the joints and then to the muscular region, we will see that the muscles here are literally how to say affecting the movement of the scapula, because the scapula is not attached directly again and again to the axial skeleton. That's why it is suspended, for example, by the rotator cuff muscles, some additional muscles which are attached directly to the axial skeleton, and so on. Okay, now what is also interesting here for us, the next portion, this is particularly our humerus, which is not well seen here but seen here. So this is the humerus, one of the representatives of the long bones, as you can see, and this this long bone is localized in the region of the brachium or arm. So what is important to remember? First of all, we do have the proximal end with the head, where we do have the spherical head, as we said, and we do have the distal end with a part of the small capitulum as well as the portion of the trochlea, as you can see here. In the proximal end, we have several important structures for the attachments of the ligaments as well as the muscles. So here we do have, as we said, we do have the part of the head itself, and the head is spherical and covered by the cartilage for the articulation with the glenoid cavity. That's okay. The next portion, what do we have here? Here and both here, we do have the structure which we call like a groove, which we call the anatomical neck, meaning that the spherical head of the humerus is having the attachment to the shaft. So that's what we call the anatomical neck here. Do you see? So in the surrounding and all of the circumference, That is the structure which we call the anatomical neck of the humerus. Next portion, which you see here, is a part of two tubercles, okay? So one is, as you can see here, the large two tubercles. So one simply is the greater tubercle, as you can see here. Please follow the cursor. And the second one is the lesser tubercle. Why they are also important for us and interesting? Because both of these tubercles, in between of them, we have the formation of the longitudinal, like a furrow, you know, like the invagination, which is longitudinal, and that's what we call simply either sulcus or groove. So these, according to the name, it's very clear that this sulcus or groove is intertubercular, saying that it is between the tubercles, and this groove is also known the bicipital groove. Why? Because here we do have the long head of the biceps brachii muscle. This biceps, which we know very well in the part of the arm. So the biceps brachii, that's why we call it biceps. It has two heads, that's why. And one of the heads is literally passing in the part of the intertubercular sulcus or bicipital groove, okay? As well as the both sides of the intertubercular sulcus are very interesting because they give rise, that's very interesting, they give rise to the attachment of the different types of the muscles. Can you imagine? So the attachment here is literally very interesting on both of the sides, here and here. You can see, and that's why we are saying that we do have the attachment to the lips or the sides of the intertubercular groove or sulcus, okay? Next portion, what comes after the region of the greater and lesser tubercle, here lower to it, where we do have more narrow structure, that's what we call the surgical neck. So normally it's not that's like that very prominent anatomical feature, but interesting thing that one of the most common fractures of the humerus are coming on that region. This is what we call, that's why we call the surgical neck. To be honest, if we'll see it here, here it is. It's very nicely seen under the in the part of the X-ray. Oh, sorry. Just let me show you. Like, for example, here you can see how it looks like. You see, this is the part of the humerus. This is the head of the humerus residing in the glenoid cavity. This is the part of the tubercle, and here you can see the part of the surgical neck fracture, for example. Yes. Or here, for example, you can see there is even the already it moved even. That's why it looks like that. Or in this case, you can see the same. So that's how it looks like. So most commonly, the part of the humerus has the main type of a fracture in the case of the proximal end of the humerus, particularly at the region of the surgical neck. So when we continue to descend through the part of the So when we continue to descend through the part of the whole shaft, let's say like that, in this case, as you can see, we do have important type of the projection on the more, it is on the lateral side, you know, of the shaft of the humerus or the body of the humerus. And this is the deltoid tuberosity, as you can see here. Or also it is very well seen on that particular region. So why do we need a deltoid tuberosity? I do believe it's clear from the name that the type of a muscle, which we call the deltoid muscle, which is localized on the proximal region of the arm, this is the one which is attached to the deltoid tuberosity, covering the part of the proximal region of the arm. As a result, posteriorly to it, we do have a portion of the radial groove, where we have the part of a radial artery as well as the nerve, which are passing through it and giving rise to the blood supply and the innervation of the upper limb, mainly posterior surface of it. Going down towards the part of the elbow, we can see the distal region of the humerus, and it's also very much important and interesting to talk about. To be honest, we have even the separate picture for that. Just a second. Here it is. This is the distal part of the humerus, which contains, which contains, as you can see here, the part of the projections on the both of the sides, and this is the medial and the lateral epicondyles, as you can see here. By the way, interesting thing that these epicondyles are the placement for the attachment of the extensors and the flexors of the forearm and the hand. So interesting thing that when we do have here the attachment, in the case of medial part of the epicondyle, there are the flexors. In the case of the lateral one, this is for the extensors. So flexors are most commonly anterior localized. The extensors are localized on the posterior surface of the forearm, but we will come to that explanation when we'll talk about the muscles. What else is interesting in this case? That if we have here the condyles, you can see that superiorly to that region, we do have the projection, the prolonged projections, which we call the ridges, supraepicondylar ridges on both of the sides. By the way, it's also, these ridges are also producing the attachment for the different types of muscles. As a result, the lateral and the medial supraepicondylar ridges are presented here. Now, what is also interesting itself, the distal most region of the humerus, and here we do have the part of the capitulum, as you can see, as well as the portion of the trochlea. So what is the capitulum and the trochlea? Here we said that we have the simultaneous articulation of the humerus with the radius and the ulna of the forearm, yes? Where the ulna in anatomical position is always localized, where? On the medial side, and in the case of the radius, it's always on the lateral side. So what is interesting to see here, this is the part of the ulna. Do you see? So the ulna, as you can see here, contains the part of the very large projection, which we call the olecranon. It's like a hook-like structure, which we call the olecranon. So olecranon on its anterior surface sure will contain the articular facet, and that's region what we call the trochlear notch. So when we talk about the trochlea itself, here, that's where our olecranon is residing. As a result, posteriorly, because the olecranon is like a hook-like structure, so when we do simply the extension and flexion, in the case of extension, the olecranon, that's what you can see particularly here, in the case of extension, the olecranon should be residing in the distal part of the humerus. And as a result, here we do have a part of the olecranon fossa, do you see, like invagination, for the olecranon to be residing in the case of the extended type of the elbow joint. Anteriorly, during the flexion, I want to show you the part of the ulna. Again, here we have a small projection, which we call the part of the coronoid process, and also the part of this is the radius and the ulna. On the proximal side, the ulna is really very large, and the radius is much smaller. And this radius, you can see, contains the head, which is residing in which, the part of the capitulum is residing. Look, this capitulum is residing in that particular head of a radius. So as a result, it makes the different types of movements, such as simply flexion and extension. It helps us in that particular movement, as well as we do have this coronoid process um, uh, of the ulna, which is during the flexion. That's what you can see particularly here. Yes, the part of a coronoid process sure should be residing somewhere. And this anteriorly, in the anterior view, you can see the small invagination, which we call the coronoid fossa, as well as on the other side, we do have the radial fossa, when during the flexion, the part of the both the ulna and the radius with their projections should be residing in that particular invaginations. Okay, is it clear this part or not? Do you have any questions? Do you have questions, guys? No. Okay, let's have some 10 minutes rest because I need to drink some water or tea even. And the 10 minutes, now it is 14:58, so 15:10 I will be back again to you. All right, thank you. We'll see you in 10 minutes.